Welcome to the deep dive. Today we're really zeroing in on a critical topic
Yeah.
using some excellent high-yield MSRA revision notes someone shared with us.
That's right. We're talking about extradural hematoma, or EDH, a true neurosurgical emergency.
Exactly. Our mission is to unpack EDH, break down what it is, why it's so dangerous, how you might spot it, and, the key management points.
All distilled from these specific notes, aimed at making it clear and memorable for revision.
Think of this as your focused guide to the must-know facts.
And it's crucial stuff. Understanding EDH, well, it's about recognizing when every second counts. These notes really highlight that.
Okay, let's jump right in then, starting with the absolute basics from the notes. What is an extradural hematoma? What are we actually dealing with here?
So, okay, an extradural hematoma, sometimes called an epidural hematoma, it's a collection of blood. It forms in that space, the potential space between the inner surface of the skull bone and the dura mater.
The dura mater being that tough outer layer covering the brain.
Precisely. And the key trigger, according to these notes, is almost always head trauma.
Got it. So bleeding outside the dura, pushed up against the skull bone. Why is that specific location such a red flag?
Because this bleeding, it's often arterial, so it happens fast.
Yeah.
And that space, it's really confined.
Right. No room to expand outwards.
Exactly. So as that blood pools, it rapidly cranks up the pressure inside the skull. Intracranial pressure, or ICP.
And that's the emergency.
That's the core of it, yeah. The notes are clear. This high pressure can lead to some really severe outcomes. Things like infection, long-term cognitive problems, epilepsy, hemiparesis, that's weakness down one side.
And the really bad one, brainstem injury.
Yes, potentially devastating brainstem injury. It's that rapid pressure cooker effect.
Okay, makes sense. So how did these actually happen? What are the main causes listed in our source material?
The number one cause, overwhelmingly, is traumatic head injury. Often, the notes say associated with a skull fracture right underneath.
And the source of the bleeding itself, is there a usual suspect?
There is. The notes point squarely at the rupture of the middle meningeal artery. That's the most common source.
Middle meningeal artery.
Less often, it might be the middle meningeal vein. And the classic mechanism, it's usually a blow to the temple area, sort of side of the head near the eye.
Ah, because the artery runs right there, it makes it vulnerable.
Exactly. Vulnerable spot. A knock there is a big warning sign.
The notes mentioned a few other, maybe less common causes too, didn't they?
They did, yeah. You can get tears in the dural venous sinuses. Those are the big veins draining the brain.
Okay.
And very rarely you might see EDHs on both sides of the head, linked to fractures near the top, along the superior sagittal sinus.
Wow, bilateral.
Yeah. And another interesting one, the notes mention contralateral EDHs. So an EDH on the opposite side from where surgery was done, sometimes happening after a decompressive craniectomy for a subdural hematoma.
Huh. That's unexpected. Almost like a complication of treating something else.
It is. Now, what about kids? Are they affected differently?
Good question. The notes make a point about children being less likely to have a skull fracture with their EDH.
Why is that? Skull flexibility.
Seems to be the reason, yeah. Their skulls are just less rigid.
Mm.
The notes also give a quick mention to spinal EDH, same idea, but around the spinal cord.
Right. Bleeding in the spinal epidural space causes there.
Things like epidural anesthesia complications, trauma from a lumbar puncture, or even spontaneous bleeds if someone has clotting problems.
Okay, so we know how they happen. Who's most at risk? If someone has a head injury, who's more likely to develop an EDH? What risk factors do the notes list?
The notes give a pretty clear picture. People involved in high-risk activities, think contact sports,
Makes sense.
Also jobs or lifestyles with a higher chance of head injury. Construction, maybe.
Sure.
A history of previous head trauma or skull fractures definitely bumps up the risk.
Mm-hmm.
And this is important. Any medical conditions or medications that affect blood clotting.
Like anticoagulants.
Exactly.
Yeah.
So yeah, athletes, certain occupations, people with prior injuries, or those on blood thinners, they're all in higher risk groups.
Right. Let's dive into the pathophysiology a bit more. The sequence of events. How does the EDH actually develop and cause problems step by step according to the notes?
Okay. So trauma happens. A vessel ruptures, usually that middle meningeal artery we talked about.
Right.
Bleeding starts into that space between the skull and the dura. The hematoma, the blood clot forms and starts expanding.
And expanding quickly.
Quickly, yeah. As it gets bigger, it pushes down on the brain tissue underneath. And that pressure is what causes the neurological signs and symptoms.
And here's the critical bit, the really dangerous part. What's the major, potentially fatal consequence of that rapid pressure buildup?
It's that sharp rise in intracranial pressure, the ICP. It can lead to brain herniation.
Explain that a bit. Herniation sounds bad.
It is when parts of the brain get squeezed out of their normal position, often downwards through the opening at the base of the skull.
And that compresses vital structures.
Exactly. Like the brainstem, which controls breathing, heart rate, the absolute essentials. So herniation can be fatal very quickly. It's the speed and the location, that tight space, that makes EDH so dangerous.
The rapid pressure is definitely the core issue. Now, when someone comes in after a head injury, EDH is on the list, but what else might be going on? What differentials did the notes mention?
Good point. Always need to consider other possibilities. The notes list several things that can look similar.
Like what?
First up, subdural hematoma. Key difference is location.
Right. Subdural is deeper. It's bleeding between the dura and the next layer in, the arachnoid membrane.
And the cause is often different too.
Often, yeah. Subdurals are typically from tearing of bridging veins, maybe from a sudden jolt or movement, not always a direct blow like EDH. And it's usually venous bleeding, so often slower.
So EDH. Shallower, often arterial, direct blow. Subdural, deeper, often venous, maybe acceleration, deceleration. Got it. What else?
Intracerebral hemorrhage, that's bleeding inside the brain tissue itself.
Different location entirely.
Completely. The notes say this is often linked to things like severe high blood pressure causing a vessel to burst, though trauma can cause it too.
Okay. Any others?
Well, the notes remind us to think about traumatic brain injury, TBI, more broadly. EDH is one type of TBI, but you have to look for other damage too. Bruises on the brain, contusions, diffuse axonal injury, maybe other bleeds.
Right. It might not be just the EDH.
Exactly. And what else can muddy the waters, make diagnosis tricky?
The notes specifically call out intoxication, alcohol, drugs.
Because it affects their consciousness level, makes assessment hard.
Absolutely. You can't easily tell what's the injury and what's the substance. And don't get tunnel vision on trauma. The notes say other things can mimic the symptoms.
That's it.
Like an intracranial abscess, a collection of pus.
Yeah.
Or a brain tumor, a mass, even seizures, or maybe TIAs, those mini strokes.
Good points. Always keep the differential broad initially. Now, let's look at the numbers. Epidemiology. The notes give a UK perspective. How common is EDH?
They state the incidence is around 1 to 3 cases per 100,000 people per year.
So, relatively uncommon in the grand scheme, but definitely significant in trauma settings.
Definitely. And who gets it most often?
The notes show it's most common in younger folk, particularly the 20 to 40 age group.
Okay.
And there's a clear gender difference. Males are affected much more often. The ratio is about 4 to 1, male to female.
4 to 1, wow. Any other interesting demographic points?
Yeah, this is striking. The notes say that while EDH only makes up about 2% of all head injuries admitted to hospital,
Okay, small percentage.
it accounts for a much bigger chunk, 5 to 15%, of fatal head injury.
That really highlights the severity, doesn't it?
It really does. The notes also mention timing, about 60% present acutely, meaning fast onset, 30% are subacute, developing over hours or days, and about 10% are chronic, which is less typical for EDH.
And what about the extremes of age? Very young or older people?
The notes say it's rare in really young kids, again, probably because their skulls are more flexible and the dura isn't stuck down so tightly yet. And it's also less common after age 60, maybe because the dura gets more adherent to the skull with age, making that space harder to open up.
Interesting. Peak age for kids.
Actually a bit older, 11 to 16 years according to the notes. And those rare spontaneous cases, they tend to happen in the 30s and 40s.
And does age affect the outcome?
It does. The notes explicitly state that prognosis is poorer in older patients, specifically mentions over 75s having worse outcomes.
Okay, let's talk clinical features. The signs and symptoms. If you're seeing a patient after a head injury, what are the classic things the notes say to look for?
Right, the classic picture. Often there's an initial loss of consciousness right at the time of the impact.
Okay, knocked out initially.
Then, and this is the really characteristic bit, the lucid interval.
Ah, yes, the famous lucid interval.
Exactly. A period where the patient wakes up, seems alert, maybe even talks normally for a while, before their condition starts to rapidly go downhill again.
That sounds incredibly deceptive.
It really is. A major pitfall if you're not aware. Other key features listed. A severe, persistent headache, often worst near the injury site.
Localized pain.
Yep. Nausea and vomiting are common, often signs of that rising ICP. And then neurological deficits, which can vary a lot depending on what part of the brain is getting squashed. Weakness, numbness, speech problems.
That lucid interval, though, it's so important to recognize it, isn't it? But the notes also say not everyone has one.
Absolutely crucial point. It's a hallmark feature when present, but not all EDH patients have a clear lucid interval, so you can't rely on it being there.
Okay, good clarification. What else is on the list?
Well, obviously a history of head trauma is usually there. The potential for really rapid deterioration is key. Seizures can happen. Altered consciousness is common, ranging from confusion to coma.
Any specific physical signs?
Unequal pupils, that's a huge red flag, suggests pressure on the nerves controlling the pupils, often meaning brainstem involvement. And focal neurological deficits, like weakness on one side. Oh, and always consider a cervical spine injury, too, with that kind of trauma.
Right, neck needs checking. And for spinal EDH, what symptoms there?
For spinal EDH, the notes mention things related to the spinal cord being compressed. So weakness, numbness, changes in reflexes, maybe problems with bladder or bowel control incontinence.
Okay, so the notes suggest you often suspect EDH based on this clinical picture, right? Especially that pattern of injury, maybe a lucid interval, then worsening headache, confusion, vomiting.
Exactly. And then developing neurological signs like brisk reflexes, maybe a positive Babinski sign.
That upward going toe reflex.
That's the one. Indicates upper motor neuron issues, and critically, that fixed and dilated pupil on one side, a really ominous sign pointing towards brainstem compression and potential herniation.
And the notes give a big warning about a procedure not to do.
Yes, a critical negative point.
Yeah.
Avoid lumbar puncture if you suspect raised ICP. Taking fluid off from below can actually encourage the brain to herniate downwards. Very dangerous.
Absolutely, vital point. Okay, clinical suspicion is high. How do we confirm it? What's the gold standard investigation according to the notes?
No question here. An urgent non-contrast CT scan of the head.
Virgin CT, why non-contrast?
Because blood shows up bright white on a non-contrast CT, making it easy to spot quickly. Contrast isn't needed for the initial diagnosis of a bleed and just takes extra time.
And the CT shows.
It shows if there's a bleed, how big it is, precisely where it is, and importantly, it also shows any associated skull fractures or other brain injuries. It's the essential first imaging step.
And the notes mention a classic shape on the CT, right?
They do. The classic description for an EDH is lemon-shaped. Or you could say biconvex, lenticular.
Like a lens.
Exactly. It bulges inwards, pushing the dura away from the skull, but it's typically limited by the suture lines where the dura is more firmly attached to the skull bones.
Yeah.
It doesn't usually spread out thinly over the brain surface like a subdural often does. That shape is a big clue.
Ottoman-shaped, got it. Are other scans ever used?
The notes mention MRI might be useful in some select cases. Maybe if the diagnosis isn't clear or you're looking for other more subtle brain injuries that CT doesn't show as well. And angiography looking at blood vessels might be considered if you suspect an underlying vascular abnormality, like an AVM, especially if there wasn't a clear history of trauma. Or to check for active bleeding.
What about basic initial tests? Bloods, x-rays?
Standard stuff, yeah. The notes list full blood count, FBC, urea and electrolytes, UNE, basic blood work.
Skull x-ray.
Can show fractures, but the notes rightly say CT is way more sensitive for picking them up and shows the bleed itself. So CT is king.
Makes sense. And neck imaging.
Crucial. Cervical spine x-rays, or more often now CTC spine, are usually needed to rule out a neck injury, given the forces involved in causing an EDH.
Right, and if the patient gets worse after the first scan?
Repeat the CT. The notes are clear on that. Any deterioration warrants a repeat scan. And again, that caution about never doing an LP if you suspect raised ICP.
Okay, let's synthesize that initial approach. Patient comes in, head injury, reduced consciousness, low GCS. What's the absolute priority sequence from the notes?
ABC first. Assess consciousness using GCS, secure the airway, ensure breathing, support circulation. Basic life support is paramount.
Airway first.
Always. Once that's sorted, the immediate next step is that urgent non-contrast CT head scan. You need that diagnosis fast. Speed is absolutely critical.
Okay, CT confirms the EDH. Diagnosis made. What's the immediate management plan? What needs to happen right now?
The notes are emphatic. Urgent neurosurgical consultation. Immediately. This is their territory.
Get the neurosurgeons involved ASAP.
Absolutely. While waiting for them or during transfer, it's all about close monitoring. Vitals, neurological status, repeated GCS checks, pupil checks, and if you have the capability, monitoring intracranial pressure directly.
And basic support.
Keep oxygen levels up. Provide adequate pain relief. maintain stability.
And the definitive treatment, usually.
For most significant EDHs, the notes say it's surgery. That's the definitive step.
What kind of surgery? And what are they trying to achieve?
The procedures mentioned are either a craniotomy, where they temporarily remove a piece of the skull bone.
A bone flap.
Exactly. Or they might use burr holes, which are smaller holes drilled into the skull. The goal is the same. Get the clot out, stop the bleeding source, and relieve that dangerous pressure on the brain.
Makes sense. Evacuate the hematoma, stop the bleeding, lower the pressure.
Yeah.
Are there specific initial steps for managing unconscious patients mentioned? ABCs.
Yes, definitely. ABC resuscitation first. Airway management is top priority, often leading intubation, but being really careful about the neck assumes C-spine injury until proven otherwise.
Gentle handling.
Very gentle, high-flow oxygen, a full trauma assessment to check for other injuries everywhere else, and IV fluids to maintain blood pressure and ensure good blood flow, good perfusion to the brain.
Is surgery always the answer? Or is conservative management ever an option for EDH?
The notes say conservative management can be considered, but only in very specific situations.
Such as?
For a patient who is fully alert, neurologically stable, and has only a small hematoma on the CT scan.
But with close watching.
Extremely close observation. That's the crucial caveat. They need to be watched like a hawk for any sign of deterioration, because things can change fast.
And how do they decide if it's small enough for conservative management?
It's based on specific criteria from the CT scan, things like the volume of the hematoma, its maximum thickness, and whether it's causing any midline shift, pushing the brain structures across.
Are there guidelines?
The notes mention the Brain Trauma Foundation guidelines generally recommend surgery for larger hematomas, anything causing significant mass effect. So conservative management is really only for a select few.
Okay, what about managing that high ICP medically while waiting for surgery, or maybe in those conservatively managed cases?
The notes list a few options. Osmotic diuretics are key IV mannitol or hypertonic saline solutions. These draw fluid out of the brain tissue, reducing swelling and pressure.
Right, pull the fluid out.
Exactly. Hyperventilation is another temporary measure mentioned, making the patient breathe a bit faster. This constricts brain blood vessels, which can lower ICP for a short time, usually done along with elevating the head of the bed to about 30 degrees.
But there's a caution with hyperventilation.
Yes, you have to be careful not to overdo it. Avoid excessive hypocapnia, letting the CO2 level drop too low, as that can actually reduce blood flow to the brain too much. It's a temporary bridge, really.
Got it. Any other medical points from the notes?
Yeah, they mention using low-dose heparin for DVT prevention, as these patients are often immobile. Also, acid suppression medication, like a PPI, to protect the stomach from stress ulcers. And obviously caution with any anticoagulants given the bleeding risk.
It really feels like the recurring theme here is speed. Why is that urgent referral and treatment so critical?
Because the notes directly correlate prompt surgery with better outcomes. It's that simple. If diagnosis is delayed or surgery isn't done quickly enough, the risk of severe permanent neurological damage or even death goes way up. Time really is brain with EDH.
Time is brain. Okay.
Yeah, the notes nicely summarize the initial trauma management. Start with the A to E approach. Always immobilize the C-spine, give oxygen, intubate if their GCS is low or airway is compromised. Then neurosurgery steps in to decompress the skull, get the clot out, and stop the bleeding using those burr holes or a craniotomy.
Right. So looking beyond the immediate treatment, what's the prognosis? What's the outlook like for someone with EDH, according to the notes? What influences it?
The outlook, it varies. The notes say it depends on several key factors. How big was the hematoma? Where was it located? How quickly was it diagnosed and treated? And were there other associated brain injuries alongside the EDH?
And that timely intervention, how much difference does it really make to the outcome?
A massive difference. The notes state clearly, timely surgery often leads to an excellent prognosis. People can make very good recoveries. But flip side, delayed diagnosis or inadequate treatment. That's when you see severe deficits or fatalities. So overall, after surgical evacuation,
Generally excellent prognosis, according to the notes, which is quite hopeful considering how dangerous it is initially.
but there was that point about age.
Yes, prognosis is poorer in older patients, specifically those over 75. The overall mortality rate mentioned is around 30%, which sounds high, but
But
it's significantly lower if the patient is alert when they first arrive. Their initial neurological state is a huge predictor.
what specific signs on arrival point towards a really poor outcome?
The notes list a few ominous signs. An initial GCS score below 8, indicating severe impairment. having a fixed and dilated pupil, that sign of brainstem compression we mentioned, or exhibiting decerebrate posturing, that abnormal extension posture indicating severe brain injury. Those are all bad signs.
Okay. The notes also touched on prevention briefly. What measures are suggested?
Pretty common sense stuff, mostly. Promoting helmet use is big motorcyclists, cyclists, skateboarders.
Makes sense.
Moderating alcohol intake is mentioned, as alcohol is a major factor in falls and injuries. Helmets for horse riding are also noted as reducing injury severity.
Anything that doesn't help.
Interestingly, the notes specifically say helmets are not effective in preventing brain injury during boxing.
Huh. Okay.
And there's also a cautionary note about the risks of repeated concussions, thinking about long-term effects.
Right. Even after successful treatment, what potential long-term problems or complications can arise from having had an EDH? What do the notes list?
Well, the most severe is ongoing neurological deficits. These could be temporary or permanent. And of course, the injury can be fatal even with treatment.
What about seizures?
Post-traumatic seizures are a known complication. The notes say they often occur maybe 1 to 3 months after the injury, and there's a higher risk noted in patients with a history of alcoholism.
Is preventative anti-seizure medication helpful?
Not routinely, according to the notes. They specifically state that prophylactic anti-epileptic drugs don't seem to reduce the rate of seizures after mild traumatic brain injury. May be different for severe cases, but not for mild.
Okay. What about less severe but still impactful consequences?
Post-concussion syndrome is mentioned. That collection of symptoms like persistent headaches, dizziness, maybe mood changes, irritability, fatigue, can linger for a while.
And specifically for spinal EDH, any long-term issues there?
Yes. The notes mention potential problems like spasticity, muscle stiffness, or tightness neuropathic pain, which is nerve-type pain, and ongoing bladder problems.
Okay. So to kind of wrap this section up, we've gone through this set of revision notes pretty thoroughly. We've covered what EDH is, the causes, especially that middle meningeal artery and trauma.
Looked at the risk factors, the pathophysiology, that rapid pressure buildup being key.
Considered the differentials, the epidemiology, who gets it, how often.
Zeroed in on the clinical features, especially that lucid interval, and the urgent need for a non-contrast CT showing that lemon shape.
Detailed the management, from ABCs and urgent neurosurgery consults to surgical evacuation, or rarely conservative management.
And discussed the prognosis, generally good with prompt treatment, but influenced by factors like age and initial GCS and potential complications.
Yeah, I think the absolute key takeaway from drilling into these notes is recognizing those signs and symptoms early, understanding the urgency, knowing why that rapid bleed outside the dura causes so much pressure so quickly.
And connecting that pathophysiology to the clinical picture, especially that potentially misleading lucid interval, and the absolute need for speed in getting that CT and getting the neurosurgeons involved.
Exactly. It's about putting those pieces together for quick recognition and action.
So here's something to think about as you revise this. We've talked about the classic presentation and the need for speed. But the notes also mention complicating factors like intoxication or other severe injuries. How do those real-world complexities, which can mask or mimic symptoms, impact your ability to rapidly suspect and diagnose EDH, especially when that lucid interval might already be making things tricky? Something to ponder in a practical sense.
That's a great point. It really highlights the challenge in busy emergency departments.
Well, that wraps up our deep dive into extradural hematoma for today, based entirely on these revision notes.
We really hope this detailed walkthrough has given you a solid, high-yield overview for your studies.
And if you are prepping for the MSRA and looking for more resources, remember you can find really valuable materials over at pastthemsra.com.
That's right. And don't forget, there's also a great selection of free content available to help you learn at freemsra.com.
Thanks so much for joining us for this deep dive.
Keep learning.
It's